Regarding pelvic fractures, the case will come as a shock case and need management regarding those guidelines as per ATLS. Regarding classification is Young-Burgers classification, that is type 1 is anterior posterior compression, type 2 is lateral compression, and 3 is vertical shear. The anterior posterior compression is grade 1, that is stretched anterior sacroiliac ligament. There is simple diastasis of less than 2.5 centimeter and protected weight bearing is a treatment. Type 2 is a rupture of anterior sacroiliac ligament, sacrotuberous and sacrospinous ligament. There is symphysis widening of more than 2.5 centimeter. Anterior fenestrine incision advised for plating. The stage 3 is the rupture of anterior and posterior sacroiliac ligament, sacrotuberous ligament, sacrospinous ligament. These fractures are rotationally and vertically unstable and treated by sacroiliac screws. Safe zone is S1 body. The lateral compression fractures are type 1, that is Riemann and ipsilateral sacroiliac fracture. Protected weight bearing is advised. Type 2 is a similar like type 1 but with ilium fracture, that is crescent fractures. There is risk of internal organ injuries and entrapment. Most common injury is head injury in this one. ORI of the ilium and the pelvic reconstruction plate with lateral compression screws is advised. Type 3 is a type 1 or 2 plus contralateral anterior posterior compression injury. This most commonly happens in pediatric fractures. Vertical shear fractures are there is a displacement. It needs anterior posterior stabilization. Anterior and posterior stabilization. Alpha transverse process fracture indicates vertical instability. Highest risk of hypovolemic shock in these cases. Similarly, there is a tile classification that's A is a stable ring, B is a partially stable ring, and C is a rotationally and vertically unstable ring. In these fractures, the most important thing is to do a Jude view to elevate acetabulum, inlet and outlet view. Inlet view will help to assess the sacroiliac joint, and outlet view will help you to identify the vertical translation and sacral fractures. A CT for definitive pelvic injury assessment. Management is per post guidelines, ATLS guidelines, pelvic volume reduction with binder and sheets. A pelvic binder is applied to the greater trochanter region to reduce the pelvic volume and realign the blood surfaces, bone surfaces, and venous stasis. It is a internal rotation of the lower limb will help to bend the knees. Can remain for 24 hours, can cause skin necrosis. If left longer, skin check should be every 6 hourly and should be exchanged for to external fixator if longer. Tranexamic acid IV is given within 3 hours as per crash guidelines. Traction is advised. Major hemorrhage is transfusion protocol is advised if volume of blood is 1 blood volume in 24 hours, that is 5 liters in a 70 kg person in 24 hours, or 50% of blood volume is given in 3 hours. Bleeding in excess of 150 ml per minute. If hemodynamically unstable, arrange massive transfusion protocol, that is 4 ratio 4 RPRPC, 1 FFP, 1 platelets. If they discuss with you packing, pack A and pack B, so pack A has factors to keep the clot, to make a clot, and pack B is to retain the clot. So fibrinogen falls by 50% after 6 unit PRPC, so you have to give cryoprecipitate. Pragmatic clinical plan is to activate switchboard, 2222. They can also talk about the rotation thromboelastography, which helps to identify which pack to be given. Then we talk about the pelvic angiography and embolization. So basically, pelvic angiography and embolization is not against, but they are complementary. Patient is on pelvic binder. If you are, if it improves, you can put external fixator or a pack. Some patient will still reduce the HB, and these patients will need embolization. Regarding the placement of swabs, bleeding is from the vein or the bone can't be controlled by embolization itself. Require laparotomy midline incision, stopper approach, and retroperitoneal packing, which should be removed in less than 48 hours. 3 large packs can be applied. One is presacral area. This will stop the bleeding in the presacral venous plexus. Then second pack is greater sciatic notch area to stop the bleeding from superior gluteal artery. And the third pack should be obturator foramen to stop corona mortis. So presacral area will stop the presacral venous plexus, greater sciatic notch to stop the superior gluteal artery, and obturator foramen to stop the corona mortis. No drain should be advised, and I will take the surgeon with me to the theater. Regarding VT, prophylaxis should be started within 48 hours. If there is a trauma and there is suspicion, IV filter could be employed. Chest injury is most common injury and needs to be assessed. How to put external fixes to show Sean's pin on each side, iliac crest or supraacetabular. I would prefer the supraacetabular pin because it do not interfere with the future intervention like surgery and doesn't interfere with the laparotomy itself. It's a positional X-fix, so don't close. Just place traction and place an external fixator to stabilize the pelvis. Regarding indication for ORIF, sacroiliac joint stays diastasis of more than 1 centimeter, uh, pubic symphysis diastasis of more than 2.5 centimeter, open fracture considering diverting colostomy for extensive perineal or rectal injuries, and displaced fractures in children more than 2 centimeter. Colostomy if done within 24 hours reduce the mortality by 50%. It should be in the upper quadrant. Regarding the retroperitoneal packing or angiomobilization, in the treatment of uncontrolled hemorrhage from the pelvic fractures, mortality rate was similar in patients who had retroperitoneal packing versus angioimmobilization. This was by Lee et al. In 2016. So they are not against each other but complementary.